Yes, please.
From below to in the cases of foramen magnum meningioma, how was the position of hypoglossal nerve to the tumor? For example, have you ever found this nerve behind the tumor or always is anterior to tumor? The hypoglossal position. This is one of my questions. And what was the frequency of lower cranial nerve palsy before the operation in your series of foramen magnum meningioma? And if the patient have preoperatively lower cranial function, what's your strategy in managing that? And this is the second question. And the foramen magnum is this.
For today it's enough.
Foramen magnum.
Yes.
Should I answer now?
If you want,
Yeah, go on.
Go on. And for the ependymoma you show, intramedullary ependymoma, perfectly you learn us that the most important part is the anterior perforator.
Yeah.
It's very important because if you take the anterior spinal artery, everything is finished. What is the trick in dissection? You know, the lateral part we can dissect and reach to the anterior. The anterior has a great attachment, or usually adhesive. So do you dissect caudal to cranial or cranial to caudal?
Yeah.
This is one of my questions.
Okay. I start with ependymoma. As you have seen, I come from cranial down, but like acoustic, I never go from one side very far. I dissect right side and leave it, and I dissect left side, leave it, and then slowly from both sides I come in order to have the. But of course, when I have done the dissection from both sides, I try to use them and crucial whatever, make it thinner and thinner, so that I have in the middle more space. And if I have more space, I can then take the capsule and bring together. Then I have more view to the midline. You know, in order to be from both sides absolutely sure when I reach the midline where the arteries are coming, and from below above down. And for the foramen meningioma, there are two different types.
Foramen magnum.
From magnum meningioma. From magnum meningioma, I think the largest series I already is more than 170 cases, and they are so different, so that you cannot answer with one sentences. They are all possibilities, and I have cases that the vertebral artery wall is infiltrated. When once you have seen that, I tried to go further, and if I saw that it is infiltrated the wall, then I would leave the part on the wall of the or when I see that the caudal cranial nerve is also infiltrated, then I am not going to risk caudal cranial nerve deficit when the patient has a normal function. That is what I would recommend to everybody, because you can leave it first and control it. And once the tumor is slowly destroying the function, the patient has no problem, because they compensate with the other side. During the one side is losing the function, the other side take down the function of the other side. And then, of course, I am not in favor of radiotherapy in this area. I have so many patients came with wheelchair with a craniocervical tumor. Please, those who are using gamma knife or radiotherapy, be careful to irradiate the craniocervical tumor. This is so sensitive area. The people not immediately, but after 3-4 years, they are sitting in wheelchair, and we cannot do anything. I think
yes.
hypoglossal nerve, you see,
The relation of hypoglossal foramen magnum meningioma
is different also. In well-capsulated, it is compressed downwards. You can separate, as you have seen in other cases I have demonstrated, you can separate like other caudal cranial nerves from the two bodies. It's infiltrated. You must be also careful to destroy that. This is also very, very important. And I think at least in my material, there are about 20% which are in this situation, that you have to be not radical.
And last question.
Yes, please.
Professor, do you agree for the cholesterol, petrous apex cholesterol granuloma? If this, you know that many of you did a very great job by removing everything, but it needs also in some cases marsupialization to outside for drainage. Do you agree if these lesions can we reach them from the sphenoid sinus? We tried this because
sphenoid sinus.
Yes, because the petrous we operated on 2 cases. And going through the sphenoid sinus, and I open it, I clean it and marsupialize it to the sphenoid sinus. Therefore, I didn't enter to the CSF pathway. Do you agree if we can do this? This is also right or not?
Yes, there is absolutely. Thank you that you did say that, because there is also indication like the posterior approach with the endoscope. You can do it also with the anterior. That's absolutely correct. What you said, I'm sorry I didn't mention that, but because when they are extended to that, and you need only open the sphenoid sinus, and I remember we have operated perhaps 3 cases at that time many years ago with Professor Draft together, and then we have just opened the wall of and everything come out, you know, because the ENT doctor are more interested in granulomas than neurosurgeon, you know. Therefore, I have this experience. You are absolutely correct. Yeah.
Thank you, boss.